So from ENT, we have a patient. Of course, fungal disease in the PNS have been a little bit in focus over the last few years. Last year, not the last few years, and but not all fungal diseases are mucormycosis, and visual loss is also not always quite because of the involvement of the globe. So ENT3 today is presenting a patient to illustrate some of the issues with fungal diseases and visual loss. It's led by Dr. Rajiv Kumar and Professor Rakesh Kumar. And
I'll be presenting case from ENT side. So our story is of a 25-year-old lady who was 3 weeks postpartum when she presented to us during the first wave of COVID-19 in June 2020. She presented to us with the chief complaints of complete loss of vision in the right eye for last 4 months and progressive loss of vision in the left eye for last 20 days. This is the history of present illness. In March 2020, during her second trimester, she started developing painless progressive vision loss on right side. In April 2020, in the beginning of her third trimester, she consulted a local treating obstetrician who dismissed it as a functional complaint which will likely improve postpartum. In May 2020, she developed gradually progressive protrusion of right eye now, followed by left eye, and she gradually lost the vision completely in her right eye. In June 2020, when she went to term, she delivered a healthy 3 kilogram baby via a normal vaginal delivery. Following the delivery, she developed acute onset painless diminution of vision on left side, while the right side continued to be blind. This alerted the patient and the family as they were expecting the right eye to recover now. At this point, while probing, she also complained of nasal stuffiness, which was on and off for quite a while, and this was associated with hyposmia and a single episode of blood-tinged nasal discharge, which resolved spontaneously. So this was the point when she presented to us, and I'll be taking you further in this story. She did not complain of any ocular pain, redness, swelling, or lacrimation. There was no associated fever, facial pain, numbness, cheek swelling, any persistent nasal discharge, cough, headache, sneezing, halitosis, or any other constitutional symptoms. In her other history, her past history, she did not have any history of prolonged hospitalization, chronic medical illness, or chronic drug intake. There was a non-contributory personal history. Her family history and obstetric history was also non-contributory. She used to have regular menses prior to this pregnancy, and she had one live issue. During examination, we found the patient to be conscious, cooperative, well-oriented to time, place, and person. She sat comfortably in the examination chair. Her vitals were stable. There was no pallor, icterus, clubbing, lymphadenopathy, or edema. Her weight was 59 kgs, height was 150 centimeter, and she had a BMI of 26. Her systemic examination, central nervous system, cardiovascular system, abdominal and respiratory examination was within normal limits. For ophthalmological examination, I would invite Dr. Monica from RPC to present the findings.
Thank you, Dr. Anupam. A very good afternoon to all in one. I'll be talking about the preoperative ocular examination of the patient. The patient presented in RPC casualty with decrease of vision in right eye since 4 months, as already told by Dr. Anupam. The visual acuity in right eye in presentation was PL negative. In left eye was hand movement close to face with PR accurate in all quadrants. The right eye pupil showed an presence of a relative afferent pupillary defect, and the left eye pupil was normally reacting. The anterior segment examination was within normal limits. The fundus examination revealed presence of a total disc pallor in the right eye, and there was a mild temporal disc pallor present in the left eye. On an extraocular examination, there was presence of a right divergent squint, and there was limitation of movement, as seen in this video. There was limitation of movement of right eye towards the medial side, towards the left side. So these findings were suggestive of a partial third nerve palsy. Along with that, there was also a mild proptosis present, which was slightly more in the left eye as compared to the right eye. Patient was then referred to the ENT department. The further management was done at ENT department, which shall be discussed by Dr. Anupam.
We did an anterior rhinoscopy and found pale, insensate, non-bleeding polyps with mucopus all around. The origin of these polyps was posterior and lateral wall, as found by probing test, and these polyps were filling the whole nasal cavity and disallowed any posterior nasal examination. Our rest of the ENT examination in the form of otoscopy, oral cavity, neck examination, and indirect laryngoscopy was within normal limits. So we made a list of 4 differential diagnoses. The first differential was a chronic invasive fungal rhinosinusitis, query aspergillosis. Second was an allergic fungal rhinosinusitis. Third was a benign nasal neoplasm. And fourth was a malignant neoplasm of the nasal cavity. We ordered a CT paranasal sinus, and the findings will be discussed by Dr. Akhil from Radiology Department.
Thank you, Dr. Anupam. We have the NCCT and MRI images of this patient, pre-op images, which is dated June 2020, few days apart. These are the coronal sections of the CT scan from anterior, serial sections from anterior to posterior. Here we can see the bilaterally the paranasal sinuses are expanded and bulging out with this hyperattenuating soft tissue. Also, we can see the lamina papyracea is bulging into bilateral orbits. However, there is no intraorbital extension of the soft tissue. Also, we can see this is the optic nerve at this level, right side optic nerve. This is the left-sided optic nerve. The right-sided optic nerve is mildly bulky as compared to the left side and is abutting the bulged out lamina papyracea. And more posteriorly, this is the optic nerve in the right side. This is the left side, which is free from the soft tissue. And these are the most posterior sections, which shows the intraorbital part of the optic nerve is free from the soft tissue. And this is the posterior most section at the level of optic canal. Here we can see the optic nerve is not anymore seen, and it's encased by the soft tissue. So we can say the optic nerve is encased by this mass at the level of optic canal. Also superiorly, we can see the hyperdense soft tissue is showing intracranial extension. However, no intraparenchymal extension was seen. So there is an intracranial extraaxial extension of the soft tissue. And it's involving all of the bilateral sinuses except for some dependent part of the right maxillary sinus. These are the serial axial CT images of this patient, again from inferior to superior. We can see this is the left nasal cavity, which is fully filled with this hyperattenuating soft tissue. Also, it involving the bilateral maxillary sinuses, frontal sinus, and sphenoid sinuses, causing expansion of all the sinuses. Again, coming to the optic nerve, this is the right side optic nerve, and this is the left side one. So, in the intraorbital part, it's free from the soft tissue. And when we move more posteriorly, at the level of optic canal, the soft tissue is involving and encasing this optic nerve. These are the bone window images, which better appreciates the expansion and rarefaction of the sinuses. We can see all the sinuses are really expanded with the thinned out rarefied walls. We can't see any definite bone destruction, but all the walls are expanded and bulging out. These are the MR images of this patient. The upper panel shows the T1 weighted images, and the lower panel shows the T2 weighted images. In the T1 weighted images, we can see the hypointense soft tissue filling the paranasal sinuses. And again, this is the optic nerve, which we saw in the CT scan. When at the level of optic canal, it's involved by the soft tissue. And in normal aerated paranasal sinuses, in T2 weighted images, it will be hypointense because of the air. In this case, because of the fungal elements and the heavy metals concentrated by these fungi, the fungal elements and these heavy metals will also be T2 hypointense. So this the T2 weighted images really underestimates the disease, because normal aerated sinus also will be T2 hypointents because of the air. And in this axial images, we can again see the optic nerve, which is again compressed by this soft tissue. To summarize the imaging, we have the hyperdense soft tissue within the sinuses and nasal cavity, and which is involving bilateral and near complete opacification of all sinuses, expansion and rarefaction of the sinuses. Also, there is a characteristic low signal intensity on T2 weighted images because of the fungal elements and heavy metals concentrated by these fungi, as I said. And apart from this bilateral sinus extent, it also causes bulging out of laminar preparation to both the orbits with no definite intraocular invasion of the soft tissue. And also superiorly, there was intracranial extraparenchymal extension, and posteriorly, the optic nerve was involved at the intracanalicular part. So this imaging wise, these features are consistent with allergic fungal rhinosinusitis with a Lond-Mackay score of 23 out of 24.
So based on radiology, we made a diagnosis of allergic fungal rhinosinusitis with bilateral orbital and optic nerve compression with right optic atrophy and right partial oculomotor nerve palsy. The treatment plan was as follows. First was to do a surgical debridement in the form of a functional endoscopic sinus surgery and a GA. This was done in an emergency setting. This was also supposed to allow optic nerve decompression in the same setting. This was to be followed by topical steroids and alkaline nasal douching, and the patient was reinforced that regular follow-up is of utmost importance along with regular endoscopic cavity cleaning. This is the surgical video. Patient's polyps were all surrounded by this fungal mark, and these polyps and fungal mark were debrided using a micro debrider under endoscopic vision. In this video, you can see the optic canal running through the posterior superior part of the left sphenoid sinus, which was fully encased by the fungal mark 270° all around, and this was compressing the optic canal. And once we decompressed it, you can see that optic canal is very well made out in the sphenoid sinus. To discuss the post-op pathology, I would invite Dr. Shraddha to discuss the same.
Thank you, Dr. Anupam. So for the pathology specimen, we got multiple mucosal fragments. These are the mucosal fragments which are lined by stratified respiratory epithelium, columnar epithelium. And in that you can see multiple pale areas surrounded by dense lymphocytic collection, which are the formation of granulomas. These are the pictures of the granulomas with multiple giant cell. There are multiple foreign body giant cell as well as Langhans cell giant cell. Then on the HE stain and in the granulomas, we found fungal hypointensities, which is better appreciated with fine tuning of the microscopic fine adjustment. On spatial stain for fungus, we did silver methanomen stain, which highlighted the fungal filaments. Here you can appreciate there is a filamentous structure. This might be a septation, but it is difficult to say in this. We did a pass stain, which also highlights similar negative fungal filaments. Here also you can see the filamentous form of the fungus. Every stain was done because in a routine case, TB is our main differential, but it came out to be negative. It was diagnosed as allergic granulomatous fungal disease, and microbiological correlation was advised. On microbiology, the species was discovered to be Aspergillus flavus. It was communicated to ENT. Yes, sir, there were multiple eosinophils. In this specimen, there were here. This HE slide here, the eosinophils have been marked. They point towards the fungal. Thank you.
So having done the surgery and having confirmed our diagnosis with pathology, we did a post-op ophthalmological examination which will be discussed by Dr. Monica.
So in the post-operative period, on post-op day 2, it was found that the vision of patient in left eye improved from hand movement close to face to 2/60, and on subsequent follow-up, it improved to as good as 6/6. The right eye vision, however, did not show any marked improvement. Also, there was improvement in the there was decrease in the amount of proptosis on follow-up. So the most recent follow-up of the patient shows a visual acuity of PL positive but PR inaccurate in right eye. Left eye it is 6/6. The extraocular examination revealed no limitation of the extraocular movement on medial side of the right eye, which was present in the preoperative period, and the proptosis is also resolved. We did a fundus examination, which we found a complete neuroretinal rim pallor on the right side, which is on the left side, the neuroretinal rim of the nasal side and the superior side was apparent to be normal. There was only a temporal and an inferior pallor. We did a OCT for the patient, which demonstrated a complete loss of neuroretinal rim, complete thinning of the axons of the right optic disc as evident by these red areas. Whereas on the left side, the thinning was limited to the temporal and the inferior quadrant. So this is the reason why the patient did not improve in the right eye, because there was already an optic atrophy that had developed in the right eye due to late presentation of the patient. Also in the left eye, the color vision and contrast was slightly reduced. Right eye color vision contrast could not be assessed because of poor vision of the patient. The visual field of right eye could not be done because of poor vision. The left eye showed a central scotoma. So we infer that if we intervene at a very early age, at an early time in such patients, it can help to prevent the development of permanent blindness. The right eye visual recovery was poor because of late presentation. However, the left eye vision recovered very nicely because the intervention was done within few weeks of symptom onset only. The further discussion shall be done by Dr. Anupam. Thank you. The right eye prognosis is not there because, as evident by the OCT finding, there is a diffuse thinning of the neuroretinal rim, which implies there is loss of axons that has permanently taken place. But the left eye does have some healthy rim fibers left, so the left eye visual recovery has taken place.
This is an endoscopic video of her last follow-up, which was 1.5 years post-surgery. And we can see a healthy nasal septum and healthy inferior turbinate on the right side. As we go posteriorly, we can appreciate the nasopharynx and a eustachian tube opening on the right side. Both are looking healthy. The endoscope is pulled backwards, and then we proceed superiorly to the sphenoethmoidal recess, which is the draining area of the sphenoid and posterethmoids. The sphenoethmoidal recess. As we go anterior and further lateral, we can visualize the middle turbinate, which is also healthy. So the right nasal cavity shows no evidence of residual disease. Going towards the left side, on left endoscopic examination, we can see a healthy nasal septum, inferior turbinate and middle turbinate. We can also visualize a healthy maxillary sinus and the sphenoid sinus in this part. Sphenoid sinus has a normal looking optic canal on the posterolateral aspect, and we can see no evidence of disease here also. To discuss the post-op radiology, I will invite Dr. Akhil.
Thank you. We have the post-op axial and coronal non-contrast CT images of the PNS. Here we can see the hyperdense soft tissue which we saw earlier filling the sinuses has all been removed, and the PNS is normally aerated. And coming to the optic nerve part, this is the optic nerve in right side and then the left side. We can see the optic nerve which had got compressed at the level of optic canal the compression has been removed. This is the right side and this is the left optic nerve. And on coronal images, this is the right and this is the left optic nerve. So all the soft tissue has been removed and the compression has been relieved from the optic nerve.
Discussion part. So I'll be talking about AFRS first. Allergic fungal rhinosinusitis is basically a type 1 and type 3 hypersensitivity response to fungal antigens in nasal cavity. These fungal antigens are almost universally cultured from all nasal cavities, and the commonly implicated organisms are Aspergillus, Alternaria, Bipolaris, and Curvularia. This infection causes nasal cavity and paranasal sinus expansion and bony remodeling. It can cause pressure decalcification of the sinus walls. To diagnose allergic fungal rhinosinusitis, Bent and Kuhn proposed their diagnostic criteria in 1994, which is still very popular till date. It has 5 major criteria and minor criteria. The major criteria include type 1 hypersensitivity reaction, nasal polyposis, characteristic CT findings which were enumerated by Dr. Akhil, presence of eosinophilic mucin without invasion, and presence of positive fungal stain. However, in the current practice, characteristic CT findings is what clinches the diagnosis, and we don't go behind proving it to be a hypersensitivity or via eosinophilic mucin presence. Minor criteria are also there to support the diagnosis. However, it's a presence of characteristic CT findings alone which clinches the diagnosis. How to differentiate it from invasive fungal sinusitis? As mucor got very popular this year, so we need to talk about it. Allergic fungal rhinosinusitis is differentiable from acute invasive fungal rhinosinusitis with the following points. Aspergillosis, Alternaria, bipolaris, and curvularia are the causative organisms for AFRS. However, mucor species is the chief driver for AIFR. Type 1 and type 3 hypersensitivity reaction to fungal antigens is seen in AFRS. However, AIFR is a purely invasive fungal infection. AFRS causes bony remodeling and thinning of bone architecture. However, it rarely causes bone erosion. AIFR doesn't respect the bony boundaries and causes extra sinus extension at the same time. AFRS has a long history with an insidious onset of symptoms. AIFR has a short history with an acute fulminating course. AFRS, due to non-infiltrative pathology, causes optic nerve compression, which is reversible unless a complete optic disc atrophy is seen, as was seen in right eye in this case. AFR, however, has an infiltrative pathology and causes vision loss primarily by optic neuritis and endarteritis obliterans, and it is rarely reversible. We published regarding these cases last year, and optic nerve compression was seen in 4 of the cases which presented to us last year, and due to some strange reason these incidence was increased during COVID-19 time last year. This was another publication from our department which was done 15 years ago, and it talks about optic nerve compression in the setting of allergic fungal rhinosinusitis. It was a 10-year audit from 1997 to 2007. It talked about 70 cases of AFRS who presented to us during this time, and 10 of these cases had optic nerve compression. 3 out of the 10 cases had bilateral optic involvement, and visual recovery was achieved in 7 out of 10 cases. Patients with long-standing visual loss or complete visual loss had significantly lower chance of recovery, as seen in this study. And what we saw in this case reverberates with this study, that patient who had long-standing visual loss did not recover her vision on the right side. However, as the history was short on the left side, she did recover her vision. For further discussion and comments, I would invite Dr. Rajiv Kumar, additional professor from ENT department.
Evening all. Thank you, Dr. Anupam, Dr. Monica, Dr. Akhil, and Dr. Shraddha for such an elaborate presentation. Take-home point for this case presentation and why we presented this case is the sinonasal disease has a very subtle symptom and patient tend to ignore. Like in this patient has on and off nasal stuffiness. Sometimes patient can have on and off nasal obstruction, and they take them as a common symptoms of chronic rhinosinusitis and tend to ignore to seek the specialist consultation with the ENT specialty, and that's why many patients present to us in a delayed scenario. Even for benign and malignant conditions, they are present in a delayed fashion. When the disease is extensive, almost 15 to 20% of the patient have ophthalmic manifestation at presentation, and 1.5 to 4% of patients have vision loss. Mostly it is unilateral, but rarely it is reported in bilateral, as it was seen in our cases. The paper we published in which there are 8 eyes in which 4 patients have bilateral, 2 patients have bilateral vision loss. So we should not ignore and we should seek a proper and prompt consultation. That is the first point. Second point is the compressive neuropathy versus optic neuropathy versus invasive. So allergic fungal sinusitis lead to vision loss because of the compression of the nerve in sphenoid sinus. And we have a window of few weeks where we can have prompt action and we reverse the vision, and as we could achieved in one of these eyes and in other patients also, which we published. But as we have seen in the second wave, we have a mucormycosis, like we can say the explosion of cases. We have more than 200 cases, and many eyes were lost during this pandemic in this group because there is angio invasion, there is endarterite obliterans, and there is no window. When the vision is orbit is invaded or there is central retinal artery occlusion, there is no going back. So that is the main difference between two diseases. This is one is extramucosal disease, compression, and on the other side, it is a true invasive fungal rhinosinusitis. And the third point is that because of this pandemic, the patient have avoided seeking healthcare facilities to look because of the fear of contracting the disease, and that has led to delay in many non-oncological diseases also, like one of these. Thank you so much. I would be happy to take any questions. So 1.5 year follow-up, and we have shown you post-op radiology and endoscopy. There is no. Yeah, the recurrence rate is quite high in allergic fungal sinusitis. Some literature reported up to 70%. So, ma'am, the role of antifungal is not there. There is a Cochrane review also because it is a steroid has a role, ma'am. Steroid post-operative management, steroid has a major role to prevent recurrences, both topical, which is intranasal corticosteroid, which patient was taking, and many centers advise oral corticosteroid also for long term. But the oral corticosteroid has their own side effects. But the drug delivery now with intranasal steroid is also very good. And we also give steroid nasal douching, intranasal corticosteroid was given, and along with saline nasal irrigation. Yes. So that was a history. We cannot take. Sir, when the patient presented. So patient was pregnant and she was seeking the consultation from local obstetrician. And when she, yes, sir, it keep on washed. Yes. So, so there are two type of nasal douching. One is alkaline or saline nasal douching. One is steroid nasal douching. So they basically wash out all the residual debris and the secretions and prevent the immune complex formation in the cavity. That help in preventing recurrence. Restart this hypersensitivity cascade. That is the role of alkaline nasal douching or steroid nasal. So there, as Benton Kuhn criteria, major criteria, these patients are atopic patients. Mostly atopic patients. They have heightened response, type 1 hypersensitivity, And the common allergen, because this is sinonasal microbiome, is this fungi are commonly present in sinuses. But some patients are atopic, they have heightened response, and then the type 1 hypersensitivity plays a role in the development of this disease. The allergy. Sir, I understand that point which is shown in the pathology that there are some filamentous fungi. The clinical, radiological, and the follow-up. Yes, sir. Sir,
I think you brought up a very good point because the literature tends to compartmentalize these very clearly into invasive and non-invasive, allergic, non-allergic. But of course, patients don't quite follow it quite completely. We have had patients previously who are predominantly allergic fungal sinusitis as this, but maybe because of the inflammation that occurs in the mucosa and the fungus that has been staying in that sinus for so long, it has also penetrated the mucosa. So this is really a patient who had allergic fungal sinusitis, but over treatment has been transitioning to an invasive phase and has been corrected at this stage itself. And of course, we have now have 18 months of follow-up and it hasn't progressed further. But we do see the odd patient with this transition. And again, quite 20 odd years ago, Dr. Chitra Sarkar for us looked at some of these patients, and 25% of our patients had these granulomas. If you look very carefully, yes. So the angioinvasive is more a characteristic of mucus. Yes.
Yeah, recede.
So systemic eosinophilia is not a general manifestation of this illness, but this is basically a local, but it does happen. I mean, it's not that it's never happens. It happens. So there are some questions which remain unanswered, and we do use them. It's not that we never use them. We do use them, and I mean, especially in a patient like this with a small granuloma or some invasion, we tend to use them. But statistically, nobody's been able to show us that it reduces the rate of recurrence.
and they are not polyforming, they are mainly slow growing masses.
And so there's so many other criteria. These are
Thank you.